So when we talk about the COVID vaccines, I think there are three sort of main categories of questions that have people concerned. First, are they really necessary? Do we need them? Second, do they really work? And third, and probably most importantly, are they really safe? So I'll try and touch on each of these for you today. And I'll try and drill down a little bit deeper on, I think, what are some of the most common concerns. So we see and frequently hear about, that the vaccine was developed too fast, that we're messing with our DNA and maybe changing something at a cellular level with these vaccines. Certainly concerns about side effects and the long-term safety, rumors about infertility, maybe that the COVID-19 pandemic is being overblown, that doctors are perhaps exaggerating the number of cases or the number of fatalities from this. And then maybe more personally, maybe I don't need it because I'm young or I'm healthy or I've already had COVID. So I'll try and hit on almost all of these. So first, are they really necessary? I think early on we had a lot of, speculation that this is no worse than a bad flu year. You saw pundits kind of putting out there that the COVID death count was inflated, that doctors were kind of putting this on death certificates or hospital charts when it wasn't really warranted, that people were actually dying of something else, and they were sort of adding this diagnosis, and that the numbers were really overblown. I don't think we're hearing as much of this anymore because people have seen just how devastating COVID has been in pretty much all of our communities in the United States, but I still will hear this every once in a while. And then you'll hear comments like this, 99.8% of people with COVID survive. I'm healthy, I'll take my chances. For this very young looking man here, that percentage might be true, but that actually is not accurate. And I'd push back when people say something like that on where they're getting their data, because there are multiple publications now out on the infection fatality rate, how many people who get an actual infection, not just illness, but infection, any infection from SARS-CoV-2, how many of them will die. And those studies show fatality rates all over the board. You can find them from as a low of 0.2%, like this person would suggest, to a high of 1.5% to 2%. And on average, it sits more around 1%. In fact, a large study just from the Imperial College of London that was just put out and looked at a lot of different data estimates that it's much closer to 1 to 1.5%. Certainly depends on your age and your underlying health, with older people being at much greater risk of dying. But kind of taking all comers, it probably sits closer to around 1%. But maybe for this young man, it might be as low as 99.8. When we kind of look at the statistics in the US, the other thing that we have to bear in mind with that, 99.8 or 99% survival is you have to bear in mind what's the attack rate? How many of us will be infected with this? This is a novel virus, presumably to which none of us have any immunity. So the eventual attack rate on this could be almost all of us. And I think a lot of us are thinking that that's pretty likely. This is like other coronaviruses to which almost all of us have been infected by the time we're 4 or 5 years old. So far in the US, we've tested positive over 38 million people. We've had over 630,000 deaths. It is the third leading cause of death most of last year, and it was number 1 in some age groups at certain periods of time. An underappreciated problem is just how many people get hospitalized with this. We've had over 2.6 million hospitalizations from COVID-19 since the pandemic began. And now a really big problem is this long COVID. And I'll get a lot more into that here in a second. But this is the idea of persistent problems or symptoms going on for weeks to months after the recovery from the SARS-CoV-2 infection. Drilling down a little more closely in my home state here of North Dakota, 1 out of 6 North Dakotans, so 1 out of 6 of all of us North Dakotans have tested positive for SARS-CoV-2. 1 out of 160 of us have been hospitalized from SARS-CoV-2, and 1 out of 490 of us have died from SARS-CoV-2. These are pretty stunning numbers when you consider this. Now, some data that's collected by the Centers for Disease Control that I think is very helpful to trying to understand the necessity of these vaccines is a data called excess all-cause mortality. So the CDC tracks all deaths from any cause by week for years and years and years, and they trend that data. So this is the weekly death counts in the United States since January of 2017 up till about August of this year. And you can see that in any given week, we've got about 50,000 at a high, usually in the winter months during flu season, a high getting close to 60,000 deaths per week. So kind of this undulating curve of 50 to 60,000 people dying every week in the United States. Goes up in the winter, down in the summer. The gold line here represents a statistical calculation of what's the sort of upper threshold of what we'd expect for weekly number of deaths based on our 5-year prior trends. So if you go above this gold line, it means we're kind of out of bounds for what we would normally expect for the weekly number of deaths based on our prior trends. And you can see in January of 2018, there was a pretty good amount of more deaths for several weeks there, anywhere from a few thousand to almost maybe 8,000 more deaths per week in the United States than we would normally expect. This was a really bad flu year. This was one of the worst flu years we've had, flu seasons we've had for sickness and death in the last decade or more. And you can see how much added excess all-cause mortality that flu season seemed to confer. Fast forward to spring of 2020, and you can see we're way out of bounds for the expected number of deaths. So this gold line is, again, the upper threshold of what we'd expect for the number of deaths from anything based on prior 5-year trends. And we're anywhere from 3,000 or 4,000 more deaths per week to a high of maybe about 35,000 more deaths per week. So one of the first questions to ask someone who says death rates are conflated, doctors are adding more diagnoses to the charts, if that's the case, then why are there so many extra deaths throughout 2020 from everything? People would have to explain what's causing all of this added death. And the obvious answer is that it's COVID. And in fact, if you look at how many of those death certificates have a COVID diagnosis on them, it accounts for nearly all of that extra death. You can see here at the very beginning, there's some in green that didn't have a COVID diagnosis on the chart, which is probably COVID was underdiagnosed. It may be too, though, that some of this mortality could be people not going to the doctor for their heart attack or their stroke or whatever at the beginning. I mean, that could have added something to this, but the obvious implication here is that COVID added an enormous amount of mortality to 2020. And in fact, the other kind of piece of this is that the mortality didn't come down and get anywhere close to our normal expected rates until about 4 weeks after the vaccine started to roll out. So this kind of gets at another bit of misinformation that the vaccine might be harming people and causing more deaths than the virus itself. Then you got a lot of explaining to do on why we had this tremendous amount of extra death that didn't seem to finally get under control until the vaccine was really rolling out in large measure. But we still are above our upper threshold up through 2021 here, but not to the same horrendous degree that we had most of last year. And of course, looking at other countries, we saw the same thing. These were these horrific images coming out of India where they had to set up temporary crematoriums for out in fields and out in parking lots for the mounting numbers of dead because they exceeded all of their morgue and funeral home capacity there. So they were putting up these temporary funeral pyres to handle all of the mounting dead. And we had our own little version of this here in the United States. These were FEMA refrigerated semi-tractor trailers that were ordered in to hospitals in New Jersey and New York in March and April of last year when the number of dead coming out of the hospitals was exceeding their morgue capacity. Had the same thing happen recently this summer here in Texas when they were exceeding their morgue capacity. I've been in practice for 30 years. We've never seen anything like this. I've never heard of any facility ever having to order, something like this to handle the excess morgue capacity. And of course, it is true that Deaths primarily are in the elderly or the people with underlying comorbid conditions like obesity and diabetes and hypertension and so on. By the way, about 47% of all Americans fit into one of those categories of having an underlying condition that puts them at increased risk for death. But even if we just look at sort of a younger age group, people that are parents of a child at home age 0 to 17, this publication in the Journal of the American Medical Association noted that almost 40 to 43,000 children were left without a parent up through February of this year. That's a 20% increase in parental bereavement. And we saw the examples of this in our own community, in our news playing out. This was the very tragic story of Mr. Rob Tierstig. Mr. Tierstig was an oil field worker, lived up in Minot with his wife and 3 children. His wife was a nurse working at Trinity Health, and I'm not disclosing any private or personal medical information. This was all in the newspapers. She was vaccinated. Her husband was kind of thinking he didn't need it. He was a healthy guy, 46 years old, kind of put off the vaccine, and unfortunately contracted COVID-19 in, I believe it was May, got very, very sick very quickly, ended up in the hospital, then ended up in the ICU. They were having difficulty ventilating him. They had to send him to a higher acuity facility in the Twin Cities, where they had to use something called ECMO, which is when you're really, really having trouble oxygenating someone's lungs. Here was a picture of him in the paper where he was in the ICU in the prone position, which is how we have to lay people on the ventilator sometimes to try and get oxygen, to get a better flow of the oxygen into their lungs. And unfortunately, he did not survive his COVID-19, very sad and terrible outcome. And he's one of those statistics, a face on the statistic of parental bereavement for his 3 children under the age of 17 that he sadly has left, along with his widow. So yes, it's true that young people may have a 99.8% survival rate, but multiply that out by kind of most or all of us getting infected, higher percentage as we move up in age groups or other underlying conditions, tragic outcomes even in young healthy people like Mr. Tierstig at the age of 46. Well, let's say you do survive it. Well, what does survival look like? Well, survival can often look like hospitalization, something we usually like to avoid. This is new cases of hospital admissions in young people, age 0 to 17 and 18 to 29. And you can see that in both of those young age groups, children and young adults, they're at their highest level of new hospitalizations at any time during the pandemic. And in fact, new hospital admissions are at their highest level since the start of the pandemic in all age groups under the age of 50. The Delta variant seems to be pushing it into a younger population. And so what happens with hospitalization? Well, we know that a lot of these hospitals, we're seeing all these headlines are being overrun, their capacity is being exceeded. It's straining and stressing health systems and municipalities. We had a recent press conference with a number of our North Dakota hospital administrators where they were warning that we are right on the brink of exceeding our capacity here. And we're already hearing about people having to be life flighted to cities outside of North Dakota because of unable to get an ICU bed. And this is data that Stanford released for their whole health system. And you can see the number of people with COVID-19 who are hospitalized, 136, 37 of whom are in the ICU, 19 on ventilators. But the standout thing is what percentage of those are unvaccinated. And all the people in red in the hospital, in the ICU, on a ventilator, are those that are unvaccinated. The people in white are the ones that are made up of the vaccinated people. 95% of the people in the hospital, in the ICU, and on a ventilator are unvaccinated. As far as we're looking here in North Dakota and most of the United States right now, it truly is, as far as severe illness in the hospital, a pandemic of the unvaccinated. And we saw how our healthcare workers had to step up last year tired, overworked, stretched, stressed, beat up, called heroes for doing their double shifts, having added patients added to their rosters. And we appropriately applauded them for stepping up to that very, very difficult task. And now they're being asked to do it again. But this time they know that 95% of the people that they're having to do that for didn't have to be there, didn't have to be hospitalized if they had taken the vaccine. That's a hard pill to swallow. They'll do it again. They'll step up and they'll do it again, and they'll get kind of beat up over this, exhausted and tired again, but it's hard. What else does survival look like? This is a survivor, Mr. Brady Monroe. Brady Monroe lives in Cass County. He's a 23-year-old young, healthy man, went to Valley City State College where he played football. Was out of college, working at his first job, engaged to be married. When he and his family, I believe on a vacation, a number of them contracted COVID. He got very, very sick, landed in the hospital, landed in the ICU, where he spent 3 months on a ventilator. He just was discharged, according to the newspapers, after spending 100 days in Sanford's COVID unit, 3 months on the ventilator. During that time, he had to have a tracheostomy. His kidneys failed. He developed multiple blood clots. He developed septic shock. He nearly died. He lost 80 pounds. And now he's back home, still going through rehab, trying to regain some semblance of his former strength and health. That's a survivor. What about long COVID? Long COVID is the persistence of one or more symptoms after an appropriate recovery from SARS-CoV-2 infection. We're seeing now article after article being published on this. And in fact, there was a perspective piece published in the New England Journal of Medicine warning those of us in healthcare that this may be our next national health disaster, Longhaul Covid, that there are so many of these people that big health systems are now developing dedicated clinics to the management and rehabilitation of people from suffering from long-haul COVID. Well, what is this? This is a compilation of 45 different studies now published on this. And they looked first at hospitalized patients. So these are people that had COVID, were hospitalized, got out of the hospital. At least 2 months later, 73% of them had at least one or more symptoms of ongoing problems from their prior COVID infection. Most often fatigue, trouble breathing, loss of memory, anxiety or depression. Oftentimes this is a new diagnosis of anxiety or depression, persistent loss of taste or smell. Remember these bottom three here for a minute, because I'm going to show you another study that may explain why some of this is happening. Now we have a really good study that was published in the prominent British medical journal, The Lancet, looking at 1 year outcomes. Similar. At 6 months, 68% of these patients that were in the hospital, these are hospital survivors, 68% had one or more ongoing symptoms. Even at 1 year out, 49%, essentially half of all those prior hospitalized patients 1 year later are still suffering one or more problems. Most often fatigue or weakness, sleep problems, smell disorder, anxiety or depression. This one I think is striking, abnormal gas exchange in the lungs. We have some sophisticated tests that we can look at to see how well we can eliminate carbon dioxide, how well oxygen moves across the lungs. 23% at 1 year had substantial abnormalities in gas exchange in the lungs. 30% had ongoing problems with shortness of breath. I mean, these are troubling, dramatic findings lasting a year out in people who had severe COVID. What if you didn't have severe COVID? What if you had mild to moderate COVID as an outpatient? This is a published study in the Journal of the American Medical Association looking at just that. Outpatients who got COVID, and how are they doing 6 months out? 6 months out, young people, 18 to 39, about 26% of them had one or more ongoing problems. And that goes up if you got older. 30% in the 40 to 64-year-old age group, and about 43% in the over 65-year-old age group with mild to moderate outpatient COVID. I mean, that's a lot of ongoing, what we call morbidity even in the milder disease. And that's, again, they found most often fatigue, trouble with taste or smell, shortness of breath. Those are the most common ongoing problems. Now, back to that study I mentioned to kind of pay attention to those symptoms they were finding out, out to a year. There was an interesting study that's been ongoing in the United Kingdom where they've been following a cohort of people. It's a part of a larger ongoing study where they're looking at brain function and brain anatomy over time. So as part of this study, this big group of people is getting ongoing MRI scans of the brain at regular intervals of time over several years. Well, the researchers that have been conducting this study said, we've got a unique opportunity here. We've got an opportunity to see if COVID had any effects on brain anatomy. So they found that 394 of their study subjects had had a diagnosis of COVID up to that time in the late last year. And they were able to match them up with 388 of their other study subjects that were similar age, similar health, and compare their brain scans after the diagnosis of COVID. What did they find? They found that the COVID-19 patients had a statistically significant shrinkage of the gray matter of their brain in 5 different areas of the brain compared to their non-infected, non-COVID-19 infected counterparts. I mean, this is very troubling that you have an anatomic correlate of damage to the brain from a COVID infection. And these people were almost exclusively outpatient COVID infections, not severe, not hospitalized, but just regular COVID in the outpatient setting. And where did they see these abnormalities in the brain? They saw them in the areas that are responsible for memories, responsible for taste and smell, and responsible for emotions. Thus, problems with memory, problems with taste and smell, problems with depression and anxiety. We are seeing anatomic correlates of changes in the brain. Well, let's turn our attention to Delta. So how is Delta changing things? Delta is one of the 4 current labeled variants of concern. The World Health Organization labels these based on their ability to be more contagious, to evade our immune system, or to cause more serious disease. Delta is the latest of these. It emerged out of India, and it appears to have much greater ability to transmit or be contagious. In fact, the World Health Organization has called Delta the fastest and the fittest. Wherever it seems to emerge, it outcompetes all the other strains and becomes the overwhelming predominant strain. In the United States now, Delta accounts for over 99% of our infections. Well, why is this? So the viruses can mutate. They can, make little changes in their RNA, which then shows up in the way the proteins around the viruses are shaped. And sometimes those changes make them more able to infect us and transmit around us and to replicate. And sometimes they make them less fit. The ones that are more fit tend to outcompete the others. And what have we seen with Delta? Well, we see that it has about 1,000-fold higher viral load or amount of virus in our nose and in our throat than the original variant. And it appears to be 2 to 3 times more contagious than the original strain. And in fact, it's being compared to have a contagiousness on par with chickenpox, which, by the way, is very contagious. For those of us who grew up in an era before the chickenpox vaccine, virtually all of us had chickenpox by the time we were 4 or 5 years old. If it came into a house, pretty much everyone in that house would get it if they hadn't had it already. And we're now seeing that it's, from a couple of studies, it may be more virulent, meaning that it might make you sicker. It appears from a couple studies out of Britain and Scotland that it's maybe up to 2 times more likely to put you in the hospital. So these are very concerning changes in the virus. And how's this playing out in the United States? This is what's called a heat map of transmission level by county back in the middle of June of this year. The counties in blue, you see here, are low transmission. The counties in yellow are moderate. And the orange and the red were considered high level transmission counties. And they assess this by how many new cases per capita you're seeing and your percent positivity on your testing. By mid-July, that was starting to heat up in the South and Southeast and parts of the West. And this is where we're at as of this last week. Pretty much high level transmission almost everywhere now, except for maybe a couple of counties in the Midwest. The Delta variant has rapidly risen, and it is kind of bearing down hard everywhere. So one of the things that I think infectious disease epidemiologists and infectious disease doctors and virologists are saying, and I think this is correct, and this is what I've been saying, is that if you haven't had the vaccine or haven't had COVID-19 already, it's very likely that you will in the next 3 to 6 months, that you'll be confronted with this and likely have infection with this. That may be mild, that may be moderate, that may be severe, that may be deadly, but you'll be likely somewhere on that spectrum of infection if you haven't had it already. So we are really kind of getting down very soon here to a very real choice of I will take the virus or I'll take the vaccine. You got to make a decision. And so if you're going to do that math, you really got to know the math here, because this really should be a reasoned decision based on the best data that we have. So if we're weighing the risks of the virus on those scales, we have to weigh that risk of death, small in most, higher in some, real, but not the biggest of all the risks. Hospitalizations, more likely, about 5 to 10-fold higher numbers of hospitalizations compared to deaths, again, based on age group and underlying health. Long COVID, possible, outpatient, younger, maybe 23%, older, pushing 40-some%. You're getting up there where it's maybe not more likely than not, but a substantial minority. And then the other thing is that we're all going to be dealing with the issues that come with having to isolate people and quarantine their contacts and all of that. What that does to your business, what that does to your school, what that does to your operations, that's almost a certainty. We're facing that already. And what that will do in the healthcare setting when you've got stretched and strapped and strained healthcare workers. Are there going to be enough of them around to be able to take care of them?